Testing 3 3. Testing. Testing 1 1. Testing. Testing 2 4. Testing. Testing 2 4. Testing 2 5. Testing. Testing. Testing 3 1. Testing. Testing 3 2. Testing. Testing podium. Testing 1 8. Testing. Testing 1 2 3. Testing. Testing 1 2 3. Testing podium. Tarrant County Hospital.
or not, but you can hang in with us if you'd like. Awesome.
He is auditing.
He's auditing. I love that.
I don't see the iPad. I don't see the
Oh, I forgot.
That's all right. I forgive you.
The Finance Committee will come to order. Good morning, everybody. Are there any citizens that signed in? No citizens have signed in to address the committee. Move on to item 3, which is approval of the minutes from the January 24th meeting. Entertain a motion in that regard. Motion by Mr. Bose. A second by Mr. Wynn. All in favor, please say aye. Opposed? Motion passes. All right, item 4, CFO report. Ms. Clark. Good morning.
Good morning. How are you?
We are well.
This morning I would like to introduce you guys to our new VP of Rev Cycle, Rory McCready. He can stand and wave. There you go.
Good morning.
He and I worked together years ago in Lubbock, and he has about 27 years of healthcare experience, both at Covenant Health as well as Grace. There in Lubbock, and he's going to be helping out with all Rev Cycle areas. So he's over billing and collecting for the patients. Eligibility will roll up through him. He's also helping out with medical services reimbursement and the contract aspects of claim adjudication, and also with managed care. So we're really lucky to have him.
Great. Welcome to the big
city.
City.
He's drinking from the fire hose this month. So glad to have him here. And then that was really the only thing that I was going to update you guys on, unless you have questions. I'll go ahead and go into the financials.
Why don't we go on to item 5, the financial update. Item 5A. He says he's auditing this course, so he's auditing this course today. We're glad to have him.
Okay, well, feel free to ask questions. So, but the way that we do our financial report, the first few slides are what we consider to be key volumes or activities that are driving some of our financial results for the year. And the first page is more about the inpatients. And we had a really healthy volume this month from admissions. They were about 2% higher than anticipated in our budget. And our case mix index, which shows how severe our patients are and the acuity of their care, has been slightly higher this year than in prior years. Also on this page, we focus a little bit more on outpatient services. The emergency department is the largest place where inpatients come into our system. Although we were under budget for this month by about 5%. If you notice, we're also it was still a very healthy volume. And year to date, we're under budget by about 2%. Urgent care was also under budget, but these budget numbers in prior year were pretty aggressive. And this was the highest volume in urgent care since last January. So even though we were under budget and the box is red for being so, it was still a very busy month. And then of course our primary and specialty care clinics. Primary care is slightly under budget, and our specialty clinic visits are slightly over budget. And that's kind of been the trend most of this year. Invasive lab continues to be a very strong service line for us. As you can see, in January, they were about 14% ahead of where we anticipated them to be. And our surgical areas have begun to come back up to prior year volumes. If you notice in inpatient surgeries, they are about 10% ahead of budget, and that's this line right here. And then our outpatient surgery, even though they are slightly under budget, I wanted to point out that this was the highest outpatient volume that we've had in 16 months, so since 2017. And that is just really, there's not one specific type of case that's driving this volume. It just seems like volumes are over. For our psychiatric mental health, we look at our inpatient, the clinic visits, as well as the psych emergency clinic, which we also call the PEC. And all of those were over budget. I do want to point out that our psych clinic visits, you can see that this year's trend is much stronger, and that has to do with the way that we are discharging patients out of the PEC or inpatient. We're actually having them schedule their appointment upon discharge. So those volumes are going appropriately up. And my favorite page is the financial metrics. You can see that we're beginning to get some of the ad valorem taxes in, and so our days cash on hand, you can see this normal trend that it comes up, it peaks in February and then I'll trickle down. So we're holding true to that. And our net AR days are staying pretty stable down on the bottom left. The FTEs per APD is a big driver for us. Over 50% of our operating expenses relate to salaries, wages, and benefits. Our end of year target is to have about 5.7 FTEs per adjusted patient day. It's kind of a calculation we do to combine our inpatient and our outpatient activity. So far, year to date, we're 4 months in, and it's 5.6. Compared to the 5.2, so we're in a favorable position. Our payer mix, it does not change month to month, and this is a year-to-date capture. The way these percentages are related is based on charges. If we ran this based on our collections, our dollars, then our connection and our self-pay piece of the pie would be very, very small. So this is kind of heads through the door look, and you'll notice that we're still remaining close to 40% for our self-paying connection patients. They're right at 37% year to date, and then we have a large Medicare and Medicaid volume. And most of our commercial over here, this 15%, really relates to, we have a lot of high deductible exchange plans that our patients participate in. But that represents all of the normal commercial payers.
What would be the an example of other?
So our other is, it might be funded by grants or research dollars. And this is really a picture of just patient bills dropped.
Right.
So this doesn't represent all of our grant revenue. We have a lot of grant revenue that comes into other operating. This is just the patient service revenue component.
Like you said, this is heads through the door. It's not our collections. It's just heads through the door.
Correct.
What
If a
classification they
patient
are.
was going to have a $1,000 charge and they all had a $1,000 charge regardless of what they collected, it would be captured on the charge activity.
Yep.
And there's several ways you can look at it, but I think for our purposes, this is a good way. It tells you kind of how our patient population, what they're comprised of and who their original payer source would be. The JPS Connection program is, again, our county indigent program. Once patients meet the criteria, some of which have eligibility requirements based on the federal poverty guideline and residency within Tarrant County, we enroll them, and this gives them access within JPS to inpatient, outpatient, ancillary services, as well as pharmaceuticals. So we always see a natural drop-off in January. You can see that it happened here. Oops, sorry about that. You can see that it happened here, and it happened again, and that is because some of these patients, the blue line represents the Connection Supplemental Program. So we have Connection patients that are uninsured, have no other insurance. We also have a secondary layer for patients who may have those high deductible plans, and when they access the health care, they're what we would be considered medically indigent, where they cannot afford that $5,000, $10,000, $20,000 deductible or copay. And the ACA plans re-enroll every January. So we see a natural drop-off in re-enrollment process. But I will like to point out, we had about half. We only dropped by 6% this year because of some new and innovative ways that we re-enrolled people versus last year. Last year we saw a 13% decline in that 1 month. So I've asked Michelle to come. Michelle, do you want to come on up? I had anticipated we may want to talk about the Connection enrollment, but they really worked this year to communicate and get people re-enrolled on a more proactive. Every year we find new ways to involve people. So do you want to tell them a few of the programs?
Absolutely. So we changed 2 processes this year. For our JPS Connection Supplemental to Insurance patients, typically every year they term on December 31st, and they're terming because their insurance may change come January 1st. In order to be on that program, it has to be a contracted plan with JPS. So we want to make sure that plan is contracted just in case it changed. So typically, if they enroll in January, they're going to expire in December. But for the supplemental to insurance plan, if they enroll in August, they're still expiring in December. So they're only getting 4 months of coverage. So what we did this year is we did an extension process. We verified, it's like 4,000 something members that we had. So we either were calling or as they came in the door, we re-verified their insurance to make sure it hasn't changed and had them self-declare that their income, their Tarrant County residents, and their household hasn't changed. If nothing's changed, we extended them for the extra 8 months that they were entitled to. So that helped our process a lot. We're going to requalify in August. Yeah, they're not getting an extra year or anything. We just gave them the year that they were certified for. The second thing that we did was the ACA. Everybody knows that the ACA penalty went away for 2019. Well, that was helped a part of our process with the exemption process. So if a patient comes in and if they they go over a certain income level, which is 138% of the FPL, we route them to the Affordable Care Act to see if they can get health insurance, because we're the payer of last resort. If they go through that process and they get the health insurance, we help them with the JPS Connection Supplemental to Insurance program. If they cannot afford that premium, that month-to-month cost, then we actually help them get an exemption with the marketplace. If they're approved for an exemption with the marketplace, one, they don't have to have insurance. They don't have to pay that penalty fee. This is in 2018 and prior. And then we can enroll them on Connection as long as they didn't go over that 250 income limit level. Well, now in 2019, there's no penalty. So we had to implement our own exemption process. So we have a JPS Connection internal exemption process. It is mirrored the same way as the ACA, and we did this only because we are the payer of last resort. We have to make sure that they don't qualify other insurance. So we implemented that process. That has helped tremendously, because with the ACA, it may take 2 to 4 weeks before we get a response if they're approved on exemption. If our process, we can tell right away. So we're able to enroll people a little bit faster this year.
So our eligibility department, and Michelle Haynes has been with us for
8 years.
8 years, and she's made some incredible changes, but we are not here just to enroll patients in the Connection program. We're here to try to find them any insurance coverage that they may qualify for.
That's correct.
So you screen for Medicare and Medicaid and some of the state programs.
Yes, and also grants as well. So we have a few grants that we screen for as well.
That's huge. And these folks here on the board are tired of me saying it, but what you're doing is so important, and thank you very much for that.
Thank you.
The other thing that Michelle has been a part of is the last 2 days we brought a team in from Epic in Wisconsin. And Zim, for you, Epic is our electronic medical record system that we have. Epic's probably the largest, and we went with that years ago. And what we're trying to do is determine those upstream activities. And DT, this speaks a lot to what you've asked us over the years to look at. And looking at the 34,000 or so patients that are enrolled in our Connection program, even though of that population, not all of them seek their care at that time, but they do enroll. So our question is how much do we interact with them to provide them care, such as handling their diabetes problems or dealing with those social determinants or upstream activities that we can begin to reach out and help them get into the system or be preventative in our nature. So what we decided to do, working with our Epic team that came down from Wisconsin and were with us for 2 days, Michelle and a couple other leaders, about 21 leaders of the organization, we all got together to try to look at that. And what we decided to do is to take our Connection program and really begin to manage that population in a variety of ways. And we'll give you more updates. We just started having those meetings, and Epic was very supportive of it. Michelle did a breakout with them, and they now understand very much our Connection program, because that's different than most other healthcare organizations. So I think it was really helpful for Epic, and Michelle did a great job. And I think that's going to be a big answer that we'll be coming to you with about how we manage that. When you start talking about population health and everything else, there's a key component to managing what we got, which we don't do. We just take them in, which is fine, but now I think manage them will make a big difference.
All right, thank you.
Thank you, Michelle.
Thanks for the question. Michelle does a better job explaining what she does. She's very passionate, and her team, if you ever have a chance to meet with her team, they love what they do and they understand why they're here. Our January financials for the month, we had a great month financially compared to budget. We actually came in at $3.4 million compared to a $920,000 bottom line. Most of that is due to some expense savings that we had during the month. If you look up inpatient service revenue for the month, we had a strong inpatient, but some of the outpatient ancillary services were a little behind where we expected them to be. So we had some underages in pharmacy, we had some underages in the ED, as you saw, but that's okay because you have some expense savings underneath that helps offset that as well. Again, this net patient service revenue is just related to patient billings. We also have a few other significant sources of revenue, one being our property tax or ad valorem revenue. We also have the Texas supplemental funding from the state that helps supplement our Medicaid population. And then we have other operating revenue that is kind of a catch-all beneath that for a variety of grants and GME funding, and everything that's not related to those top three falls into other. For our operating expenses, again, the largest component is going to be salaries and benefits, and you can see that those were favorable as well this month. We did a really good job with holding overtime and also flexing our staff to certain volumes. Our purchase service and supply, yes. Well, if you look year to date, so the second line here is contract labor. And that's kind of the way that we budget for things. So we budget for all positions to be filled. We do assume there's a certain vacancy that kind of rolls through and churns throughout the year. But there are some key positions and coverages that we have to fill with contract labor while those positions are open. So some of this budget is for planned contract labor. What comes through is the planned plus those coverages as we're looking to fill full-time positions. So even year to date, this contract service is over budget, but hopefully we are also under budget in salaries. So those two kind of offset each other. It's a good question.
Before we go on.
Yes.
I didn't mean to interrupt you, but the number I do want to highlight for everybody in the lower right-hand corner, which is year to date, we're a third of the way through the fiscal year.
Mm-hmm. Yes. That is critical. For those of you who remember, we closed this year's margin with just over $1 million for the 12 months. Now, most of that related to some changes in formula funding and items that were impacted back at the state level, but we were able to continue to operate at just above a break even. So for us to be in a financial position the first 4 months where we do have this level of, have positioned ourselves ahead of budget is a great thing. I will tell you, when I get in front of leadership, they hear one hopefully resounding thing from me is that any given month can change our financial position, and we put ourselves in a really great position so far. As we move throughout the year, and we're sure that there's not going to be any major changes, there are programs that we're holding that have been budgeted. You can see in the $6.2 million worth of savings, probably about a third of that is true savings that will not occur. But there's probably, $3-4 million that could be caught up later in the year. So as we become more comfortable with the financial performance, we'll probably catch up on some of these operating expenses. But yes, it's a great position to be in.
Just anecdotally, those of us that have been around here a long time remember discussions that revolved around the FTE's per adjusted patient day. And 10 years ago, we literally compared ourselves to the marketplace, and the marketplace was shooting for a 5.0.
Right.
We looked at that and basically concluded there's no way.
Right.
No way. No way. We were around 7. 6.4, 6.5. And now here we are. We're at 5.56.
It's-
Talk about the variables that impact this.
No question.
We get that number down and try and find
Yeah.
out on these, but it's really achievement. So Robert, congratulations. That's a big deal.
Yeah, it's,
And I appreciate
the acknowledge of that, because the team has worked exceptionally hard, and there's a group of people that are not only watching that, and then that speaks to what we're trying to do to manage those patients that come in the door far better. We hope to be able to come to you with other additional savings, because the one thing that JPS is not going to get is a treasure chest of money. It's never ever going to be delivered to our door that says, oh, by the way, or we're never going to be in a situation where we make a substantial gain from our patient base. So what efficiencies can you create, or how do you manage what you got? So thank you. I appreciate that, Trent, and so does the team. Sharon and her team and everybody else has done yeoman's work to get that to that level. We're going to keep trying.
That is one of our major drivers. So, one of the other, we had Leadership Connection earlier this week, and I recognize the mental health team with some of our outside medical services, which is what the largest piece of some of those permanent savings. And just by, implementing some innovative ways to make those processes more efficient, they're saving $1.4 million year to date, $600 at a time. And so, it adds up very quickly. And, I think all of our leaders have really started to evaluate spend, and, you might find $1,000 and it doesn't seem like a lot, but for 12 months, my bottom line was $1.2 million. And so it's all hands on deck.
Yeah, well, congratulations.
Yeah.
Okay. Any other questions about January? We kind of skipped around there, but okay. So if you look at Acclaim, our physician organization, our billed encounters for the month were slightly under budget, but year to date, they are still about 1% ahead of budget. So you can also see another important indicator for the physicians is how much do they spend per encounter. And if you look at having trouble with my operations here today. If you look at the net operating expense per encounter, it is favorable year to date by about 1.5%. And that 1.5% is over 79,000 encounters. So again, when we get to their income statement, you'll see where they are performing well ahead of budget. This is a graph that just kind of tells you the bigger pieces of who comprises our employed providers. And this is both physicians as well as physician extenders. And then for the month, I've already kind of shared with you, they came in about 15% under their projected budget of a $2.5 million loss from operations. Year to date, that number is $1.6 million. There's a lot of variances in here because as they try to ramp up and hire all of the budgeted providers, we have some underage and patient service revenue, but we also have some salary and benefit savings. So it all kind of washes out in the bottom line, and that is kind of the end result. So we're just under $7 million year to date.
Sharon, where do hospitalists fall on that?
The hospitalist, we contract with Sound Physicians to provide our hospitalist services. And that is actually a coverage agreement between
So there's no claim representation.
they are
within
not
the hospital.
employed.
Okay.
Now, Acclaim will manage the physicians themselves and some quality indicators, and we have some other large pockets of contracted. Our ED is covered by a contracted group as well, and anesthesia.
Yep, okay, thanks.
So on the combined income statement, again, we have the hospital, Acclaim, the foundation, but the one thing that I did want to point out today is that, I'm sorry, I can't see that over there. We are actually breaking even year to date by close to $1 million from a combined standpoint. And then when you add our interest income to that, we're just over $6 million. Is there any questions on the financials today? Okay. It's me.
She's next. Sharon, good report, Sharon.
Thank you.
Entertain a motion to accept
entertain
Ms.
a motion to
Clark's
approve.
report. We have a motion by Mr. Powell, second by Mr. Bose. All in favor, please say aye. Opposed, motion passes.
opportunity, like Trent said, and it was a good report.
Absolutely, absolutely.
Great
All right,
job,
Sharon, I
Sharon.
think you're still on deck here for item B.
I am. This is a agreement for sort of a lease with Chase. It is 16 square feet.
This is my favorite one every year.
This is where legal comes into play, right? Since it's
First
considered
Amendment.
real estate, I am asking for your approval of a continuance of a 16 square foot lease space for our ATM that is positioned right outside of McDonald's in this space on the first floor.
Mr. Chairman, since it shows nothing against another bank, I would certainly make the motion to approve this for another institution that has an ATM within these walls. So I'll make a motion. No, it's not one of my machines.
Not one of
That's
yours.
why I
Just
make the
clarify
motion.
that, yes.
I have no
Not one of
conflict
yours.
in making this, or no connection with that bank. So
Before we entertain that motion, any questions for Sharon on this item? Okay, we have a motion on the floor for Mr. Powell, second by Mr. Nguyen. All in favor, please say aye. Opposed, motion passes. Thank you, Sharon. Ia Walker, item C. Good morning, Pia.
Good morning, everyone.
Morning.
This morning, I would like to ask for your approval for the administrative service agreement for Cigna Health and Life Insurance. This is for our medical and dental benefits. For the FY19 year, the cost will be 2.37. Estimated cost is 7.1. We did go to RFP for the vendors, and this was the chosen vendor that we chose due to cost and service and relationship that they currently have with JPS.
So it's a new deal, but they're the incumbent.
Yeah,
So,
they're the incumbent, yes. This is who we have worked with for the last several years.
got it.
Yes.
Any questions for Pia on this item? It is in budget. I will entertain a motion for approval. Motion by Mr. Bose. Second by Mr. Petty.
Okay.
All in favor, please say aye. Opposed? Motion passes.
Yes, thank you.
Thank you, Pia. Dr. Duncan. No, but do you want to?
Good morning.
Karen.
good morning, Doctor.
I always feel like I'm coming before you with a school-based clinic agreement. And again, I will not disappoint you, and I'm coming before you to consider for your approval the partnership and agreement between Arlington ISD and the Tarrant County Hospital District.
These are so important to our community.
Yeah.
So, any questions for Karen on this item? Entertain a motion. Motion. Did you actually said a motion for approval? Oh, all right. Motion by Dr. Schrader, second by Mr. Bose. All in favor, please say aye.
Aye.
Opposed?
That's not opposed.
Are you opposing?
No, Mr.
Charlie
Chairman,
Powell's
I'm not-
against
I'm
school-based
not- I'm not
clinics?
opposing,
Is
Mr.
that what I
Powell.
understand?
I voted positive.
Oh, voted in favor. Okay, good.
You know, again, Trent reflected again on FTEs and all that earlier. This is a program, I remember not too many years ago, we said, school-based clinics, even people in the community, what is that? What's JPS getting into? And I think, again, with the current leadership we have and what we did as a board, again, we're delivering the mission of the organization to the community. So I think it's been a program I think we've been very proud of, Robert. Hopefully that fits with your long range, but it's been a tremendous program. We hear nothing but very positive things in the community for school.
Absolutely, over and over. So unanimous vote. Thank you.
Thank you.
Dr. Duncan. Motion passes. Dr. Elliott. Good morning.
Good morning. Thank you for having me. I'll start with actually our first item on the agenda for consideration for approval for JPS University of North Texas Health Sciences Center GME Formula Funding Agreement. This is the next iteration of our agreement that we had one prior to this. And as you see, the amount there for $815,360 to support our graduate medical education funding there and to pass that through to us. This is for the fiscal year 19. But additionally, as you'll see reflected in the agreement will end February 29, 2020. So we also reflect an additional payment that will occur for the fiscal year 20.
Got it.
So this could be upwards to 1.7, we anticipate.
Okay. Pia, in terms of the I'm sorry, Dr. Elliott,
Yeah.
in terms of the pass-through, the 80-20 piece,
Yes.
is that standard?
It's not necessarily standard. It was something that we actually had negotiated prior, considering that we had not had an agreement in place before, and really wanting to support some additional activities for our faculty through the academic health center model, which we do need to have some of that for our teaching programs.
Right.
So that's where we have supported some faculty development activities. We're actually going to be exploring, now that they have some new leadership, some additional opportunities to support our faculty and our residency programs.
And that's what they're getting for their, or what they're providing for their 20%.
Yeah, and we'd like to see even more from that. So we'll be negotiating that this year,
great.
and looking
Okay.
at what that reflects for us too.
Oh,
Yeah.
Second.
Thank you. Yeah. Next item, considering approval for a Fourth Amendment to the Medical Education Affiliation Agreement between Oral and Maxillofacial Network and our Tarrant County Hospital District. This is in support of our OMFS program and supporting the educational activities and the programmatic activities supporting our OMFS residency program. As you'll see, the term over 35 months and the costs there, and this corresponds with our practice management service agreement also.
got it. Heard Dr. Elliott's explanation. Any questions?
So moved.
Motion by Dr. Petty. Mr. Petty.
My question is, what are you a doctor of?
You don't want to know.
Second.
Second by Mr. Bose. All in favor? Please say. All opposed? Motion passes. Thank you very much.
Thanks, everyone.
Kenny Carr. Item G. Good morning. Okay.
So I would like for everyone to consider the approval of the purchase agreement between Part Source Inc. in the Tarrant County. Part Source Inc. is a vendor that we utilize to supply us with parts for our clinical engineering department so that we can maintain all of our equipment. It is a 3-year agreement at a cost of about $320,000 a year for a total of about $960. They allow us to do a great job about sourcing our parts.
So we source our parts from Part Source. I could have sworn that was an auto parts place when I read that. Any questions for Kenny on this item?
It's hard to get a defibrillator there, sir.
There you go. All right, entertain a motion. Motion for approval from Mr. Nguyen. Second by Dr. Schrader. All in favor, please say aye. Opposed? Motion passes. Thank you, Kenny.
Have a great day.
You too. Wanda People.
Good morning.
Morning.
Good morning.
The first contract I would like to present is your consideration between Alcon Laboratories and the hospital district. And this is used by our ophthalmology department for our eye implants, packs, and supplies. We did put this out for RFP and only got one respondent. But when they came back, came back with a price increase, so we renegotiated that for an additional $40,000 to $45,000 annually.
We didn't get a hometown discount or anything?
Yeah, they're not hometown. They're not hometown.
I know. Any questions for Wanda in this item? Yes, sir. Please.
A while back, we agreed that we were not going to separate interns from residents, and we're going to use the term residents to include all the people in training, and this one has residents and interns.
Oh.
Good point.
Just minor sort of housekeeping
So noted.
thing.
So,
Okay.
Correct. Okay.
Other questions for Wanda? I'll entertain. Motion by Dr. Weber, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you. Next item, Wanda.
Our next agreement is with Johnson & Johnson Healthcare Systems and the hospital district, and this is for our implants that's used currently by the orthopedic surgeons, neurosurgeons, and trauma procedures. Primarily things like pedicle screws, those type things. We did put it out for an RFP. We did have 4 respondents and landed with the Johnson & Johnson product, which is DePuy and Synthes. This will give us a savings of $66,443.
Great.
And will lock us in for 3 years with this pricing.
Any questions for Wanda?
Move approval.
Motion by Ms. DeBose, second by Dr. Weber. All in favor, please say aye.
Aye.
Opposed? Motion passes. And item J is here because it's a sole source, correct?
Yes, sir.
Yeah.
This is the only company in this area that supplies this product. This is for our breast milk mothers with the Mothers Milk Bank of North Texas. This supplies us with breast milk for those mothers who want to breastfeed, but for some reason they have an infection or something, but want to keep their babies on breast milk. So this will lock us into pricing for 5 years without an increase. So as this contract came up for renewal.
Right. So the motion on this, if to approve, we need to, right. I'm way ahead of you. I'm like lapping you and stuff. Is two part. One is to approve the exemption to competitive bidding, and the other is approval of the item itself. So I'll entertain a motion.
Recommend approval of the sole source and for the agreement.
Motion by Ms. DeBose, second by Mr. Nguyen. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Wanda. Report of legal. Scott.
Mr. Chairman, there were 41 contracts that are under $500,000 for the month of January. They're posted to the board's web portal for your review.
Okay. Any questions for Scott on any of those items? All right, we're going to reconvene in executive session for a briefing from our CEO. Okay, we'll reconvene in open session. Just want to make one announcement. Next Finance Committee, we're going to combine planning and finance. There's some issues that overlap, and we thought it best to use everyone's time to do them at the same time. So we'll have a little presentation for you then. 2 chairs. Trent and I will arm wrestle. Oh, and HR is canceled for March? Planning's going to coincide with finance. All right, no further business. We're adjourned.
Thanks, Chairman.
Good afternoon, ladies and gentlemen. It is 12 o'clock, and we will call the governance meeting of the JPS Health Network to order. I'm going to give everybody a few minutes to get settled in. Hopefully the microphones are on out there and they can hear that we've started. Well, welcome. I'm sorry that it's been a while since the last we spoke. It was October. But this committee is so efficient that we were able to make this happen, this first meeting in January. Are there any citizens wishing to address the committee? Seeing none, committee chair report. I don't have much. I'm sorry? Minutes. Oh, I missed the minutes, sorry. God, I'm just off the mark here. Yeah, it is. The minutes for the October 25th meeting were included on the board portal as well as in your packets. Are there any changes? We've got a motion by Chairman Powell. Second by Dr. Weber. All in favor? Any opposed? Thank you. Minutes are approved. By way of committee chair report, I don't have much today other than to say welcome and sorry for the extended absence of this committee. But Ron and Michelle had promised us lots of fun stuff coming up, so we'll let them get to it. Ron, do you want to come up and for item 5, please, ERM update, compliance program report, and approval of policy RC 200.
Good afternoon. Yes, it has been a while since the committee has met, but there's been a lot that has taken place in the last several months, and so much so we've had to break up some of the material between this meeting and the April meeting so that we wouldn't overload this committee for this meeting today. But I wanted to start with... I'm not sure I understand. Oh, damn it.
We can finally hear DT in a committee meeting.
I have never heard of more.
DT, can we use your computer from all the meetings now, because we heard that loud and clear. I mean, we might need to get a little deeper tone in the voice, but it's great. Yeah, we'll count it. We heard it, so.
No, that was perfect. Yeah, no. I'll make sure to be more clear next time. So from an ERM perspective, there's been a lot of activity that's taken place, and for just as a reminder, what I've mentioned in the past about enterprise risk management is that this is the third year now that we're entering into in 2019 since we identified the 10 areas that we talked about 3 years ago of enterprise risk. And so it's time now to take a fresh look at these 10 areas and to see if there's any adds or takeaways. And when I say takeaways, I don't want to get it misconstrued that any of the areas are no longer any areas of focus. It's more of how far have we come in terms of mitigating risks to a level of maturity to where we can put them on maintenance mode. And so that'll be upcoming in the upcoming meeting. What I can tell you that's happened in the recent weeks is the interviews have begun around the updated enterprise risk assessment interviews, and they've been done in conjunction with Laura Burnside's work that she's doing around refreshing the organizational strategy. And so all of you as board members will be a part of those interviews as you always have, but there'll be additional questions that are kind of more top-level questions around the purpose of JPS, and there'll be more to come around that. So I thought it was since this was happening in conjunction this year that we could just combine the effort so you don't have to get hit up for 2 meetings versus 1. The second thing is at the April meeting, we had a good discussion in where we stand with behavioral health from a risk standpoint. And so I'm going to ask Zelia to come at the April meeting to kind of present to you as board members and where we are from a behavioral health perspective on that risk profile. And then lastly, what we also have underway is we are doing a pilot with the consultant, Grant Thornton, to look at one of the areas, patient experience and patient access, that's one of the 10 areas, to do a couple of things. One, to do some kind of testing as to whether our approach is consistent with other approaches that other hospitals and county hospitals are taking, to see if we need to do any tweaks or course corrections to how we're presenting the risk information. And then secondly, to set up a blueprint of how we report these that will be sustainable going forward. And so this is a small project in terms of a pilot. It's begun now. We anticipate it concluding sometime in the mid-April timeframe, and you'll obviously see the results of that as well. So,
Ron, I have a quick question.
Yes.
Do you have a timeline for when the board would need to be clued in on the interviews for the ERM assessment?
I do not. I'm coordinating the scheduling of that with Laura and her team. I'm one of 4, I believe, interviewers that's going through this process.
I guess, is there a time in which the interviews y'all want to stop so that you can compile the information? I want to be able to report back to the board that we need you guys to speak to somebody by X date.
Oh, I got you. Let me come back to you on that. I don't have a time frame yet. I know we're going through all the internal interviews now, and then you as board members will be toward the end of the interview process, so you'll have the benefit of be able to hear the trends of what we're hearing and that type of thing. I know that's what...
You know, we need lots of heads up and lots of time
Yes.
and hand-holding and scheduling.
Yes.
So.
Did you want to comment on that?
Weren't you thinking, and again, I'm not trying to put words in your mouth, end of April was about what you're looking at, so we can kind of give a guideline from a time standpoint? And again, if that's not it, that's okay. If it
No, I mean, from my perspective, I think I would probably guess about a fourth of the way through all the interviews now, and so end of April I think is a reasonable expectation.
That will give you a bit of an idea of just looking at the end of April and then giving you guys briefings and give you a little bit of a timeline. If that's fair.
No,
to you,
that's
and
helpful.
I want to make sure we have 100% participation, or I've got to sick Ms. DeBose on them. So.
No, thank you for that. I appreciate that. Any other questions from an ERM perspective before I move on to compliance? Okay. So in compliance, I have a couple of headlines, but before I get to the headlines, I have a brief announcement to make. We added a couple of new staff team members to compliance to fill some roles, which is great. We're upgrading our talent. One of our staff members is joining us from Conifer Health Solutions. It's a revenue cycle company, and she has a lot of coding background. Will be joining us as a coding auditor. And another is joining us formerly from Parkland. She's an attorney and is going to be working with us in the privacy area. And so we're really upgrading our talent in the staff level. I wanted to at least make you guys aware of that. The unfortunate announcement I'll have to make is that Yolanda at Rich has decided to go back home to near the Atlanta area. She actually took a position, an executive position in compliance in Tennessee. And so her and her family are relocating back there, and is closer to her daughter in Atlanta as well as her family in Birmingham. So, she wasn't here long, but we really appreciate her efforts, and so we're looking to kind of restructure in that way. So, wanted to make those couple of announcements. From a headline perspective, as you know, when I bring up these headlines, I should move the slide. I try to identify areas either that we have done some review and audit work in that's relevant to JPS, or that is kind of more of an industry-wide effort from a governmental standpoint. And so in this first case, with this orthopedic hospital in Oklahoma, they had to pay a little over $400,000 for allegations that they billed Medicare and Medicaid, as well as TRICARE, improperly, and they essentially they received overpayments for the misapplication of certain coding modifiers, some of which we've talked about in this committee, particularly modifier 59 and modifier 25. As a result, and this was an interesting case because this orthopedic hospital actually self-disclosed this, so it wasn't anything that was found or anything. They self-disclosed it, and because there was an indication through prior audit work that this was an issue, and the government didn't feel like they did enough to address it after they knew that there was an issue. This part of the reason why the fine was what it was. And so This is just another reason why we do what we do, is obviously is we bring these things to light so we can find and fix them. And certainly, if management doesn't take them seriously, this is what could result. I think you'll be very pleased to hear, kind of where we are in this regard, a little bit later. The second one, it's been a while since I've talked about this, but this is a very big topic in the healthcare compliance arena, the Yates memo. Sally Yates was a former DOJ Assistant Attorney General and sent out a memo during the Obama administration indicating that for organizations that had fraud or misconduct identified in their organizations, that they would not receive cooperation credit from the government in terms of lesser sentences, lesser fines, in terms of cooperation credit, unless they fully cooperated with the government and relayed to the government all relevant facts, and the key was all. And so that was kind of had a chilling effect in compliance, because when you say all relevant facts, that could also mean attorney-client privilege materials and other kinds of things that aren't typically disclosed in those kinds of things, and so it was potentially breaching attorney-client privilege. Well, more recently, and this is kind of what has happened here more recently, Rod Rosenstein, who's Assistant Attorney General, actually revised that guidance and said that organizations will get some cooperation credit if they provide relevant information, not all information, but relevant information, which is a little bit more reasonable from that standpoint, and that they have an effective compliance program. And so, again, the OIG's guidance around the effectiveness of a compliance program is a mitigating factor if fraud or misconduct is identified. And so this was a relief, I think, to the industry, because this is DOJ guidance across the board, not just in healthcare, but it certainly applies to healthcare. And so in some of the cases. And so they relaxed some of this to allow a little bit more of a reasonable guidance. And then I think the most significant piece of this that people were talking about is that for individuals involved in an organization, that's executives, board members, if they were found to have been complicit with whatever the fraud or knew or should have known, then that information should be provided as well. And so there hasn't been a lot of cases that individuals have been held accountable for some of these fraud cases, but that's kind of where the DOJ is going. So those are the two compliance headlines. It is time, once again, to update our conflict of interest disclosures for employees and physicians. We are soon to launch our new disclosure, electronic disclosure. I know it says March 1st on the slide. Actually, it's going to be the 15th. We're still kind of working out some of the challenges with because we have a new platform that's going to give us better ability to track not only who complied with doing a disclosure, but also what was their disclosure, what remedies, if any, need to be taken with their disclosure. And so the name of the software is called COI Smart. And so we're targeting the March 15th for that to be sent out. And then employees and physicians have 60 days after that date to have all of their disclosures in, and then we work through what was disclosed. From a recovery audit contractor perspective, I think we mentioned at the October meeting that the HMS, which is the recovery audit contractor for the state of Texas, that's contracted by CMS, is very active, and so actually, take that back. HMS is contracted by the state of Texas, because they do the Medicaid racks, and so given our Medicaid population, they continue to be very active in giving us letters for inquiries. The inquiry letters do not indicate that there's a problem, but it does indicate that they are trying to see how good our coding and billing documentation is, because as we talked about last time, HMS gets compensated through a contingency. And so if they find anything that they believe we were overpaid by Medicaid, then that's a potential recovery that we'd have to pay back. And so we're working greatly with HIM, Patient Financial Services, and Care Management, many of which are here today, collaboratively to work through that process. Any questions on that before I move on? Okay. One of the things I wanted to before I go on to the next item, in your portal, as is always the case, we did post the compliance dashboard that includes the cases that we've looked at since the last meeting. Most of the cases, as is most usually the case, are HIPAA privacy related. Again, with our new staff person that's going to be on board here soon, we're actually going to take leverage the tool. I think I mentioned to you all, we have an electronic monitoring like most big places do, to where we can monitor accesses in Epic that potentially are red flags or problematic proactively, as opposed to waiting for someone to tell us whether or not there may or may not be an issue. And so that's been a great tool, and it was able to leverage our resources in that way. All right, so that concludes the compliance report.
Any questions regarding the compliance report? Ron, let's talk about approval of policy RC 200.
Okay. So
we have there's no public internal audit reports. There will be some in closed session.
Yes.
So policy RC 200.
So RC 200, record of care 200, and the related procedure 201, RC 201, were updated. There wasn't a lot of updates, but there is one substantial change which I'll bring to your attention. In working with IT and the General Counsel's office, one of the things that we identified, and really, through David's leadership as well in bringing this up from an IT perspective, is that JPS has didn't have a specific retention policy around emails. And so emails at JPS could be retained for indefinite periods of time. And so there got to be a point to where some people were using emails as their own filing system, as you would expect. And so no organization of any size does that anymore. And so there's usually some kind of retention period after which those emails are purged through a normal process. And so in working with General Counsel's office, we went through what state requirements are and for county hospitals and so forth, and we came into a agreement on a 4-year retention policy for JPS emails. So those emails that are older than 4 years would be systematically purged by the IT department going forward, and that would do two things. That would save money from a cost standpoint in the expanding storage cost that David can talk about that is ever increasing, but also from a legal and e-discovery standpoint, it's consistent with what most organizations is doing. So it's not like, but the one thing I will say is that, and this is the concern that some people raised by this, is that this does not in any way impact legal holds. So where there are matters that are ongoing, those will be cordoned off as a legal hold, even if they're older than 4 years, or other types of matters that are retained in this retention schedule that would not be subject to this. So that's why it took a while for us to work through all of that. And Scott, I don't know if you want to add to that.
I believe you just said it. The legal hold was the biggest part, but there are other exceptions as well.
Mm-hmm. Right.
Well, they're listed in the policy.
I read your policy, and you had several different sections on it. Are you talking about the one that you said you'd keep for 3 years? Is that what you're talking about, your exceptions?
There are other reasons to retain the records longer than 4 years beyond just the legal hold. Is all the point I was making. Our big concern was the legal hold.
Okay.
Mm-hmm. Yeah.
Is it safe for us to mirror the HIPAA retention, which is 6 years?
You mean for PHI?
Yeah. But for HIPAA stuff, you require to retain it to 6 years.
Yeah, well, medical record information, PHI is typically that. Yeah, that is 6 to 7 year. But
this is specifically email traffic.
This is email traffic.
Does
Yeah.
that mirror what we're doing since there's no policy? I'm just questioning. To be on the safe side.
So that's a good question, and we looked at it from a perspective of anything that's in the email that should not be part of the electronic medical record, right? So we went back and said the communications that are happening in email, the policies state that you shouldn't be doing anything in email that has anything to do with electronic medical record or treatment of patients. So if that's happening, we have other systems to be able to do that, and that's where that HIPAA guideline comes in. So we have not looked to modify that based on HIPAA. We were looking at it to modify this email retention policy based on what the Texas state statute is. And quite frankly, Ron has been a good partner on this. We've been working on this for the last 3 years to try to get this done. And it's no longer feasible for us to say, let's keep things indefinitely. And for many reasons, but it really puts the organization at risk if we keep things indefinitely. And right now on my email server, we have emails that go back to 1998, 1999. And that's a risk to the organization. We shouldn't have that any longer. Right.
But did you guys reference back to SOX 2 compliance to see if they have anything that may give us a...
We did. We actually went through SOC 2 compliance. We also went through the NIST framework. We went through the high trust framework. We went through the HIPAA and the high-tech laws as well to come up with this 4 years. 4 years is actually, in the DFW area, still the longest email retention policy. So when Parkland has a two-year, Cook Children's has a 1 year, Dallas Children's has a 1 year. So we're still on the very edge of conservativeness on this, right?
Well, my question would be, is 4 years too long?
You know, so you can only change culture so fast. Okay. And when we really looked at the risk of what we'd be doing to our organization, going from, they have 20 years of email sitting out there. Yeah. 4 years seemed to be that sweet spot that Texas would allow us to, General Counsel would allow us to. And I was comfortable with that because we can still work within those guys with the exceptions of legal holds. And we have now a defined process on how to deal with that. So obviously, you know, certain things that may even be happening currently at JPS, we're carving those off so that those will stay perpetually forever.
So you'll go to each employee with a mailbox and say, if you have something that's a legal hold, it needs to go here, and
actually,
how does that work?
No, that's actually a really good question from a procedural perspective. I hate to say this, but I have a really good relationship with General Counsel right now, and with Ron. And so what ends up happening is all of those legal holds come through my desk.
Why do you have to hate to say that?
I don't know.
You just have to hate to pay the bill.
Exactly. But we actually have a procedure in place where everything comes through my office when there's a legal hold on a document. So it's a one-stop shop. So we're not going to every individual, all 6,500 employees, to be able to say, here are do you have anything that we shouldn't delete? Right. We have a very defined set of documents of the things that we're holding currently, and that's what we'll continue working off once we start this automated purge. The other thing that I think is important is this statute is all about a differentiation between someone deleting an email and a automatic electronic purge of email, right? People that are sitting there and they delete their email and they're doing things that maybe they permanently delete an email, I can't recover that. This is for the automatic purging of email after a certain date. So we need to be really clear about that when we're describing this.
Does it apply also to terminated employees?
Yes, so we hold those terminated employees' mailboxes. It's a great question, especially, again, some of the things that we're currently going through. That's a great question because we hold on to those terminated email boxes for the same retention schedule as this. So we will hold on to those.
Yeah. And so for the Freedom of Information Act, the policy is 4 years, so we can automatically disregard any request that comes requesting something 5 years ago.
Well, we would want to make sure that the PIA didn't encompass something that had been held for a legal reason, or if it fell in the very, very other minor areas that might have a reason to have held on to it more than 4 years. But if we no longer are in possession of the document, we're no longer in possession of the document.
Okay. Yeah. How do you, for the 6,500 employees who are going to get some kind of notice saying your email box is being purged, can they just go and download all their emails to a hard drive? Or?
So the answer to the question is yes. I mean, the human factor of this is not something that I can always control. Can they immediately start trying to do everything? It's no different than if we had paper electronic medical records or paper medical records and they went to a copy machine and started copying it. There are certain things that are out of the technological control. So yes, people could go and download it and then save it off and do some things. We have other technologies that would be in place at that particular point in time that this policy wouldn't see, called data loss prevention, DLP technologies that won't allow for those types of things to happen, but this policy is not in the middle of that, right? So we would institute other technologies to help with that.
So if a Freedom of Information request came in, I guess, would we know somebody downloaded all their emails so that there's a record of it somewhere, and we knew somebody had the record.
Yeah, that's a really tough question, and one I don't have a good answer for.
What
Yeah.
about backup copy of those on-site, off-site?
Right, so our backup copies are 30 days, right? So we always have 30 days. So you could almost say this is like 4 years and 30 days, because we could always go back to that. But that's where policy would come in, and working with General Counsel's office and Ron's office, that says if someone were to request something at 48 months plus 3 days, would we actually respond to that, even though our policy says at 48 months, we're not going to have that email. The fact of the matter is, from a technology perspective, yeah, we have it for another 30 days after that.
Yeah. The key thing from a change management standpoint, which is the people aspect, is that once this policy is approved, as you as board members approve it, there is going to be a communication plan to the workforce around this change, because it is a significant change for them. We're going to work with JR's group in communication. We're going to go through Leadership Connection and all the other JPS communication channels, and before the implementation date, which I think we're targeting for May or June or somewhere around that time frame.
All I can see is we're deleting it here. You've sent it to somebody else, and then suddenly it'll show up.
Well, yeah, I mean, so let's also take a look at that. I mean, when you send an email, you've lost control of that email, right? And so if someone has sent an email, forwarded on, did a response to somebody, we don't control the email policies of that end of this. We're just controlling the email policies of within JPS.
We just need to be prepared that when something come up, that's probably going to show up.
Yeah, that's a great point.
Well, the great luxury, Dorothy, in your case, is we don't have your email address. We don't seem to send you anything on time anyway, so this is perfect.
I have more of just a cleanup question. So the policy is record of care management, RC 200, but the procedure is RC 201, records management program procedure.
So yeah, and Scott wants to weigh in on this, but as a board member, you approve policies, and so RC 200 is before you for approval. However, if you look on the portal at RC 200, you'll see that there's really not any substantive change to RC 200, because the language around the 4-year retention of emails is in RC 201 and its related attachment. So
I'm just curious as to why it's not RC 201, record of care management procedure.
You mean for approval?
Yeah, well, it seems to me that they should align.
The language should align.
The language is different.
Oh, I see.
I mean, I'm just saying. I get it. It's a 200. It's a 201. But
the typical. No, that's a good point. The typical nomenclature is that policies are end in even numbers. 200, 300, so forth, and then procedures start with 01, 02, 03. But Scott, did you want to add anything?
Something that just needs to be addressed.
Yeah, we'll just kind of need to fix that. Yeah.
I was looking at, on the face of them, they look like they were two different things. Was the only.
As far as the titling is concerned.
Titling. Gotcha.
So, I don't care. I don't have a problem with the policy. I don't have a problem with the procedure. I just,
No, that's a good point. We can fix that in terms of consistency.
Policies and procedures have historically always had two numbering differences. So you always knew, looking at it before you went through it, what was a policy and what was a procedure. But if you want to change the entire history of JPS for 115 years, we're fine to
Might as well start today. I've got to 146, right, Dr. Weber?
Exactly. 146. Ron is correct. The policy is before you for approval.
Right.
The procedure is here for your information.
Right.
Yeah.
I was just noting.
I just want to make sure
the names are different.
This will carve out and retain the stuff that what we have ordered by the court or something for record retention.
Oh,
Yes.
absolutely.
Oh, yeah.
So that would be the exception.
Yes, that's one of the exceptions.
Yeah, it's one of the exceptions. Yeah.
Yep.
Does anybody have any further questions? We need a motion to approve policy RC 200. Moved by Dr. Weber, second by DT Nguyen. All in favor?
Aye.
Any opposed? It passes.
All right. Thank you.
All right. We will. I'm going to hold this meeting over, and then we will adjourn to executive session at 12:30.